pretty new procedure in the States. You've been commercialized for a year about?
Yeah, just a little bit over a year.
Perfect. So this device indicated for bilateral stimulation of the L2 medial branch of the dorsal rami as it crosses that transverse process. So what are we doing? We're really trying to stimulate that multifidus muscle and reactivate the muscle, and we'll get into how that works. So this is kind of what happens before you get reactivated. Why patients have this chronic lower back problem. You have an injury or an overloading, then you get this inhibition. I think a lot of people don't understand that inhibition. You send patients to PT and say, activate your core, right? And you can't. There's been studies out there that show you actually can't activate the multifidus as much as you try. Like, no one can sit here and say, activate the multifidus. Even if we wanted to, but then when you have this inhibition, the brain won't even turn on that part, which starts to alter the neuromuscular control. You get atrophy of that multifidus, which leads to instability and lower back pain. So this is the arthrogenic inhibition I was talking about. This is why you can't do it. And a lot of people understand it better with the knee for some reason. If you have knee pain, it is known that you'll have atrophy of your quad. And that's not because you're walking around all day saying, don't fire my quad, don't fire my quad, right? Your brain actually won't fire a quad because of that feedback mechanism of pain. The same thing happens in your back. When you have back pain, facetogenic, discogenic, whatever the pain's coming from, your back is telling you not to fire the muscles around it, which is the multifidus muscle. And this picture in the middle, the blue, green, yellow picture, actually shows that mapping of a healthy patient and a patient with lower back pain, and how there's a difference between DM there is deep multifidus, and LES is the other lower back spinal muscles, where in a healthy patient, they can differentiate between the two. And for people to understand, the multifidus should be firing what we're doing right now, as we're just standing, walking. If I have to lift something or extend, that's when the rest of your lumbar paraspinals should start to fire. In an unhealthy patient with lower back pain, your brain can't differentiate between the two, so you're almost exclusively using your larger lumbar extensors. Therefore, that multifidus atrophies, and that multifidus is what stabilizes the spine 80% of your day. You lose that, you start getting dysfunction, you start getting facet pain, you start getting disc pain. And as docs, we treat those pain, right?
Absolutely.
We're kind of just masking the issue when we're treating the pain. This will actually restabilize that spine, and I'll talk about in a little bit how it gives you an extra boost to that physical therapy side of things and actually gets these patients healthier.
So you're not just trying to treat the primary problem as opposed to the effects, but you're also hopefully giving the patient preventative care.
Exactly.
Right? Yeah, so that's great.
I love it. So we're going to go over a little data. I love data. Going to do it quick here though, because we're more about showing the procedure and talking about some of the physical exam maneuvers. But this is their study against sham. Always love companies that go against sham because I think it's very hard to do. One, it's very hard to get it approved. Two, it's hard to get people to sign up for it. And three, it's hard to win that study. Right? What I mean win that study is when you set up these studies, you don't know if it's going to be a good study or not. Right. So it's a big risk, and I like companies that take that risk, because if you do win that study, that's huge against sham. So what they did was implant 204 patients, turned it on at sub-threshold level in 102, and turned it on at an optimal level, therapeutic level in the other 102. And as you can see, big sham response, as we always see in every sham controlled procedure. But then that starts to wear off. And then that mark there where the two lines end, they allow patients to cross over. And I think even more there what you see is those patients that were in the sham ended up going back down. And I think one of the cool stats you guys told me was that you asked every patient if they thought they were in the sham or not. And I think something like 60% of patients had it wrong, where it would have been 50. So almost everyone, there was no one knew if it was on or not.
It was a toss of a coin.
Yeah. So I think that's pretty cool that they did that. I always like to ask patients, This slide I'm going to go over real quick, but what's the point of this slide is that you could have any pathology. All these patients were in that study. They had disc degeneration, facet arthropathy, spinal listhesis, rectal listhesis, disc bulge, modic changes. All these patients can benefit from reactivating. Why is that? As I talk about this all the time, there are two silos. There's a silo where you're treating pain, and there's the rehab silo. And unfortunately, all we've had for years in the rehab silo is physical therapy. Right. And acupuncture, cupping, but physical therapy modalities, chiropractic care. Now we have that cap on that silo where we can actually do a procedure to keep this silo going while you can still treat the other pain issues at the same time. So I think that's when people ask me all the time, well, would you treat the modic change or would you do reactivate? You can do both. You can do both. One of them you're just stopping the pain, the other one you're trying to stabilize the spine. Let's go over the procedure. So this is basically showing where the electrodes are going to be. I'm going to show you guys live though, because I'd rather do it live than in the setting of the slides. So let's see what kind of shot we have here. Take a shot there. Okay, great. So pull towards you just a little bit. We can get that. All right, perfect. So a little bit of a scoliosis in this patient. We've already preloaded a little bit. We cheated a little bit. But what I'm going to show out to you here, and you guys can see my hands here. We have 2 blocking needles. So where do these needles go? It's just like a medial branch block at L2, which is the L3 transverse process, but you're not coming at that oblique angle. You're literally just going straight down onto the junction of the SAP and the transverse process. And these are just giving you twofold. One, a guide of where you want to end up, and 2, when you do that final twitch test, you can, if the patient's a little larger, it might be a little harder to see the muscle actually twitching, so you'll see the needles twitching to each other. One thing I tell people all the time, do not put lidocaine down these needles, because then you'll turn the medial branch off during your case and you won't be able to stimulate. So then the next step, and so the right side is going to be the first few steps. But basically you take this needle, the gauge, 20? 18 gauge. 18 gauge needle, and we're going to find our starting spot. And our starting spot is usually right over, take a shot there, right over, see where it's X, that X marks the spot? One more shot. And one more. Good, our starting spot's right there. And that's really over the spinous process of the level below. So since we're at the L3 transverse process, that's going to be the spinous process of L4. And we're going to take that angle now from that moment, and you're going to do a cut down, just like you do the way I describe it, patients or physicians understand a little better. Same cut down you do with an SCS, right? Exactly. You're going to do that cut down first, not because you're going to put anchors in, but you're going to end up making a string or leaves loop. So you're going to do that cut down first, and then that's going to be your starting spot. And what our trajectory is going to be is we're going to go lateral from the medial line of the spinous process, trying to hit right on that spinous process marker. And I think we can do it. Okay, yeah, I'll be able to do it. Shot. So if we look at that left side there, I'm going to pull this needle back just a little bit and then advance it back in. Shot. So I'm going to do most of this in the AP first. So let's say I get there. I'm there, and I'm going to advance. Get over the TP. A lot of times what you're going to do, you want to be as close to that TP as possible. So a lot of times what you're going to do is actually hit that TP and kind of walk it over the top. And then once I kind of hit the TP, get to this mark, I'm going to go lateral and check where I go. It's nice to not have gloves on to help this yarn.
And this is a straight needle, right? There's no bent angle to this needle that you can utilize. So you have to have a perfect trajectory.
You do, and take your time doing this. You know, the procedure is the needle in my mind. If you get the needle in the correct location, everything else is going to go very nicely. So I'm going to wiggle this needle, just go live real quick, just so you can see which one we're working with. That's the one right there. So what does our mark want to be here? And you can kind of see it with the other side. We want to aim right at the inferior border of L2, the posterior inferior border, the vertebral body of L2. That's what you want to aim at. So we're coming right in there. You see our 2 blocking needles come down the top. We want to go right into that border shot. And it's always nice when you already have it on one side because you kind of just follow the same shadow. I'm going to push this a little further just so you can see it. And we want to get through the intertransversary muscle that lies there. And that's the muscle that lies kind of between the levels, the transverse process levels. You want to punch through that. And why is that? It's because when we're going to put our lead in, and we'll talk about this one more time, but when you put your lead in, this is tough. The guys in the VR might be able to see it a little better. There's bidirectional ties at the end of this lead. And that's why you don't have to anchor, because this will actually stick in that muscle once it's deployed through the sheath. And we'll do a push-pull test, you'll see it, and you'll be able to anchor this into that muscle. And it stays very good. I was actually very surprised the first time I did it.
So it saves you a lot of steps.
Oh, it saves you a ton of steps.
Yeah,
no anchoring. Great. I always tell SDS companies the worst part of the whole thing. Yeah. I hate it. I'm like, some of them, it's been a lot of years now, they should have figured out like something or whatever. So we're in there with the needle. The next step is to use a guide wire. And this guide wire is going to give us access to that area so that we can put the sheath over it. Shot. And you can see that guide wire coming through here. So, shot. Good. So it poked through. One thing that can happen if you're not through that muscle, it'll actually deflect cranially, almost at a 45-degree angle. No hurt. It just means you haven't poked through that muscle. It's actually a pretty nice check to know you're through. The other thing I always mark here is people think we're in the foramen, right? But we're not. So let's come back AP. You actually use the foramen as a marking of where you want to be here. The nerve is nowhere near where we are, because when we come back AP here, you'll see we're way lateral, right? So you see on the left side there, shot, see that guide wire coming out? That's where we want that guide wire to be. So the next steps, we're going to kind of cheat here. I'm going to pull this needle out. Perfect, shot. So we have our guide wire there. Now, the next step, which I'm not going to do live because it can be, it's not tough, it's just be a little tough on the models. In a patient, it actually goes through really nice. You make a nick in the fascia here, and you slide the sheath right over. This is just a 7 French.
Correct.
Pretty normal. So I'll get down to the part where I'll show you, slide it right on. This guide wire, you know, just make sure you're not pushing or pulling it. You want it to stay in that spot, and you slide it in here. Actually, shot. I get you halfway there. So you can see it kind of slide right over that needle. Shot. But I want to pull it out so we can see the lateral better. And you want to make sure that you get right where you want to be. I usually do this in lateral. I want to stop there. I want to pull this side out though, because we already have it on the other side, and I want to be able to show the lateral a lot better.
And if you're doing a lot of peripheral nerve stimulation implants, this is almost the same kind of approach in
Very
terms of
similar.
the tool sets, the guide wires, the tie-ins on the leads, and the introducers. So if you're familiar with that, this is going to be very straightforward.
Very similar. So we got this in on the left side, we'll say. Now we're going to switch to the right side. All I did to get to this right side moment now is I pulled up the guide wire. And we're in the same location. So take a shot there. So we like what it looks like in AP. Let's go lateral, make sure that it's still pointing at that L2 vertebral body. And if it's one of your first cases, I always say this: imaging is your friend, time is your friend. There's no record, you know, that you're trying to break. Take a few more images, lateral, AP. It's really important, because the last thing you want to do is throw the lead in there and not stimulate the nerve. And the only reason that would happen is you're a little posterior to it and you missed it. So take a shot. But this is perfect. That's exactly where we want to be. We're going right at that inferior border of L2. And now the next step is pretty simple. We take out the interior portion of the cannula. Shot. Perfect. It's a little hard to see without the inferior portion, but now we're going to put the lead down. Shot. And I don't like to go all the way because I don't want to accidentally deploy it. And how does it deploy? So Jason, I think you explained this point exactly how we deploy this and how it works to get stuck in that shot.
Yeah, absolutely. So you're going to advance that electrode so that that distal set of tines is just on the anterior aspect of that intertransversari. And once that's there, bring that sheath back a couple of centimeters, 2, 3. That's going to expose the proximal set. And then I think you're going to be able to actually show us that kind of a pull push, which is then going to snug those 2 tines up on either side of that muscle.
I think that's great. So I like to go AP here because I always check twice before I deploy anything. Make sure nothing moved. What I want to see on the AP, I'm going to give you a little hint here of where we're looking for this image to be. I like to have the first or second distal electrode right at the level of the superior border of that L3. That means you're going to cover the whole medial branch. You'll get that stimulation you want. So since we already checked the lateral, you can deploy here. And a lot of people, I think the best thing Jason said there, I want you to say it because I'm going to say it again, is you don't deploy by pushing the lead in. You deploy by pulling the sheath back. I've seen it. We're in a case, they push the lead in, you're like, oh, because that's where we want the lead to live there, right? So I don't want to push it in. And once it's deployed, you can move it, but it's a little tougher shot. So there. See how I just pulled the sheath back? We know with the lead that we are, the proximal time is just on this side of that distal lead. So we know now the lead's deployed, it's out there. We can take the rest of this out. I always go slow though too. You don't want to pull out too much shot. Make sure, you know, we're not moving it too much. When you pull this out, the inside left will come out with it as well. Shot. Perfect. And now we do our push-pull test. And you get in there. Tug it out a little bit. Actually, go live here. I like to go live here just to show it off. See how you can actually see it wiggling back and forth there in that muscle.
Yeah.
Those tines do a pretty darn good job of staying in there.
Have you issues with migration?
So that was my first question when I met them,
Right.
of course, because I've done some PNS, and that's always like that. You get the post-op imaging, and you're like, yeah, well, they moved. So I'll let you answer that because you have some pretty good stats on that.
Absolutely. It's something we're really proud of.
Yeah.
Of the 204 patients in the ReActiv8 trial, there was not a single lead migration.
Yeah,
So we are far below 1% globally.
yeah. So even commercially, which I always think is the real test, like get this in the hands of people who aren't in the study, that's what's going to really start screwing with it. Not seeing the migration is pretty impressive. That was one of the questions that. So just to finish up with the procedure part, and I'm going to show off in the last 10 minutes here some of the physical exam maneuvers and talk about patient identification. So there's a battery. This is the battery. Very similar to any other SCS battery. Kudos to the company too, they are getting it smaller, correct?
Absolutely.
In the next year or two. I don't know the timeline, don't quote me on any of that. But it's similar to an SCS, and you put it in just like any SCS perm. Right on the left side, flank, or the buttocks, however the patient likes it. I talked to them beforehand about that. The one difference is that we talked about there's no anchoring, so you will make something called a strain relief loop, which I'm just going to do outside the body here. Oh no, I can actually put it in there. There we go. Chop. And you can see on that, come down just a little bit. There we go. You can see on that C-arm image there, we would have 2 leads in here, one on each side. You want that down around, that just takes a little strain off those, you don't want to push and pulling, and then you tunnel into your flank spot that you'd like to go. This just gets tucked in on the ipsilateral side, so what I do is just make a midline incision, use my finger with a some kind of lap or something, just use my finger, make a little pocket underneath the midline incision and place that in there, and then batteries, just like any other battery. Post-op, you know, I close with just sutures deep, and then we use something called a Close-X or staples or suture, whatever you're happy with on the skin. No antibiotics needed post-op. I don't give anything for pain post-op. Tylenol and ice goes wonders. If a patient needs anything, I would do a day or 2 of pain meds. We don't turn it on though for 2 weeks. So that's one thing that you really have to talk to your patients about. And we're going to get into this in the next segment here where we're talking about patient identification. We're talking now. The patient really has to buy in to the ReActiv8 procedure because it doesn't, it's like going to the gym. You're not going to go to the gym one day and get big biceps, right? You can tell I haven't been to the gym for 4 years. But you're not going to go to the gym one day and get big biceps, right? You're going to have to work those muscles. And they turn it on for a half hour in the morning, a half hour at night. And the data is showing 2 to 3 months is when the patient will start to notice some kind of relief. What patients have told me though is they feel the stimulation, and that actually gives them a little sense of it. But the actual pain relief can take 2, 3, 6 months. There's even late responders that can take up to a year. So shout out to one of the colleagues with ReActiv8, Ralph Shiroff. He says he doesn't consider anyone a failure until 12 months. So I think that's great. But the patient has to buy in beforehand, right? You have to have that conversation beforehand. We're not even turning it on until 2 weeks. So at my 2-week follow-up, everyone's like, I'm like, yeah, I haven't. All I've done is actually make 2 incisions in you. You know, so they turn around at 2-week mark, half hour in the morning, half hour at night, and then I follow up with them 6 weeks, 3 months, 6 months, and 12 months.
Why do you wait the 2 weeks? Just to get them through post-operative period?
Yeah.
Let it scar into place?
No, it's a great question. I think it's a combination, right? We're going to be contracting that muscle that's right underneath the incision, and we're going to be contracting that muscle that's going to pull on those tines. And that contraction is actually much stronger than what you would normally see if it's just walking around day to day. So we want to make sure everything settles in so that we don't have any issues.
Okay, that makes sense.
So great. Let's. We have 8 minutes left. I think that's plenty of time. We're going to bring in our physical exam maneuver guy. I think this is great for MedEd Combine. Not to show off the procedure, but to show off some new physical exams that are out there. I want to take this off so I can move a little better. Anyway, I'm going to do that.
Jeez, you gotta wear it for the rest of the day.
Oh yeah. There we go. So I'm going to show you guys some physical exam maneuvers and how to identify these patients. So on this slide, if we can go back to the slides for the people out there, I know we're bouncing back and forth. We're going to, first on the left, that's one indication, is talking about multifidus atrophy. You can see in the circle there, those deep multifidus muscles. If you, first of all, I talk about this anytime I talk, you should be reading your own MRIs. If you're doing anything more than just injections, you need to start reading your own MRIs. So, and you may not, though, have been looking at the multifidus, and that's okay. A lot of people haven't been taught that. A lot of radiologists aren't looking at the multifidus. But you're going to start noticing this multifidus atrophy, and what that is that white coming on there against the spinous process, against the facet joint there is where it really starts to start. And you'll see that at L4-5. L5 is one region is where it really goes. But we also have physical exam maneuvers that we can do in order to show off or to include these patients. And I think the best, a lot of people go to the MRI, but the B study didn't use any MRI for inclusion. It actually just used the testing. So first we're going to talk about the multifidus lift test. And I do something, I like to, the multifidus lift test we can do lying down, but I like to do it actually standing up. And everyone can do it right now. There's a bunch of people in this room, I'm going to make them all do it. Everyone at home, stand up real quick. So put your thumb right on your L4 area, right on the spinous process, and move it one finger breadth to the left. Okay? L4 is right in the middle of the back. Here, we'll have, so right in the middle there, you're going to put your thumb right there, just to the left. And you're going to just bring your right arm up and down, and you should feel that activate, that it should be bumping out there. You guys, I wish I could show the other side. Putting their arm
It's like
around.
we're doing the wave.
So if that isn't a strong reaction, a strong punch out there, then that's when you know there's some multifidus atrophy. Because you're not activating your, I'm not extending, I'm not lifting anything. That's just your body not falling over, you know, because your compensatory band is not falling over. And then you do the other side, same thing, see if it comes out to you. So that's a quick test I always do to see if a patient is in or out. Basically, I just put both my hands there, and I put one arm up and one arm down. I think that's great. But then the PIT, the prone stability test, we're going to do here. So usually you do it at the end of the table, but I don't think we'll be able to see you guys well. So I'm going to have Tim just lie over the front of the table with his leg. Should be good. With his legs on the ground. And what we're going to do is do a glide. I don't know if the next slide talks about it a little bit. Yeah. We're going to do a glide at each level and see if there's pain. So you say, you have pain there, Tim?
Nope.
You have pain there, Tim?
Nope.
Can you just put this lateral so they can see? You have pain there?
Oh yeah.
Oh yeah, that's the one. So, and I'm going to continue down all the way. But that's his L3, L4 area. That's probably L4 right there. And the way I do it is you don't want to use a bony prominence. That'll actually hurt everywhere. You want to use either the fleshy part of your hand, just like any other glide you've ever done in the back. The great thing is too, that Mainstay has done for us, they've come and taught our physical therapists, they've taught our nurse practitioners how to do these tests. So this is just for you to get a flavor. So first we have pain. So boom, that's not a positive test yet, right? They have pain in the back. Next thing you're going to do is have the patient hold on to the table and say, lift your legs. So lift their legs off the table, and now they're activating their big muscles in their lumbar spine. And you go through again and say, do you have pain there? 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 No pain at all. That's a positive PIT test. What's that telling me? That's telling me that when he's activating all of his lumbar muscles, there's no pain. But when just the multifidus is supposed to be stabilizing, there is pain. So that's a positive PIT. Takes, how long that takes? 2 minutes? People always complain, these physical examiners take too long. This is where we'll get into this again. I'm PM&R trained, and you're anesthesia. So
But I think at the end of the day, you have to do some sort of testing.
yes.
And it gives you a lot of information.
Oh, huge.
You can wait weeks, months to get an MRI sometimes. But if you did an exam, you at least have an ability to make a very good diagnosis.
So I think if you have a patient with chronic lower back pain and you do the modified multifidus lift test and the PIT test, it gives you an idea of where you're headed. It doesn't mean every patient is going to go into ReActiv8 or that way, but it gives you an idea. You have to get your hands on the patients, guys. We always talk about that. It's very important to get your hands on the patient and help them out in that way. So I think, yes, this is the last slide. This is the slide where I kind of talk about the silos, right? One more time. For ReActiv8, we're in the restorative silo, correct? Focusing on rehabilitation, improving function for patient, reactivating that muscle control. We're teaching the brain again how to activate those multifidus muscles. And on the palliative side, we focus on masking more of the pain and treatments, injections, opioids, all those kind of things. So overall, I think it's a great new procedure out there. It's FDA approved. You really reach out to you guys. How do they get a hold of you guys to get trained or get more information?
They can go to mainstaymedical.com. There's a request for more information link right there. You'll get directed to someone on the team, and we'll make sure that we get out and take care of you.
Awesome, guys. Well, I think it's a really cool procedure out there. I think a lot of patients, the one thing I didn't talk about is what the age range is for this patient. These aren't the 70-year-old patients. This isn't your spinal cord stimulation age range. These are the 35 to 55-year-olds that want to stay active, want to keep moving. Here in South Florida, I have golfers, the boaters. They don't want fusions. They don't want to be on opioids. You know, they want to keep moving. With this procedure, it doesn't just mask the problem. It fixes the problem. It gets them stronger, gets them moving.
It makes it
Very
the
impressive. Yes.
only stimulation device that actually regenerates muscle.
Exactly.
That's pretty.
It's pretty cool.
Yeah.
Very cool, guys. Thank you very much for coming.
Thanks again.
You guys are great. Awesome.
Appreciate it. Good job.
Good
Well
stuff.
done. Well
I think that was another.